Thank you so much for the very kind introduction. Really excited to be here and tell you about our work in smart and autonomous robotics for surgery and answer the question how AI fits in our work. So quick disclosures, inventor on several patents that are licensed to startups and some larger companies. So why are we interested in smart and more autonomous surgery? Of course, really large market. Over 300 major surgeries are performed every year. On the robotic side, often we are still scratching a little bit the surface. Just about 1 to 2% are using robotic assistance. The market is rapidly growing. In developed countries, of course, in prostatectomy, as an example, we have very large market penetration. And now going into more and more procedures. So very dynamic, large market for us. Our first speaker of the session already alluded to this. This is a big motivation for our work, is this rising caseload that you have to deal with, right? We have an aging society. We have fewer and fewer surgeons. And we as engineers need to give you tools to really, cope with that rising caseload. What are robots good for? Why do we need robots in surgery? One of the big motivation is that it allows you to perform surgeries less and less invasive, going from open surgery to more distal, dexterous manipulation. You need robotic tools to help you with that. First laparoscopic, and now single port, and then natural orifice access. Of course, we all know that the invasiveness scales with blood loss, recovery time, scarring, so really much better for the patients. Current teleoperated surgery has increased the number of minimally invasive surgeries, but overall probably not reduced complication rates. The other, trend, is that some portions of surgeries are becoming more autonomous. So this graph shows like the levels of autonomy from a 2017 paper, going from level 0, no autonomy, all the way to full autonomy, level 5. So our vision is that we can augment some critical portions of manual or teleoperated surgery with robotic precision, with increasing use of using the robots, so with increasing levels of autonomy. So surgeons can then, take on a supervisory role while the robot executes a small step, like placing a suture, and watch the robot and then only intervene if necessary. So that could potentially reduce complication and then also democratize access to, expert surgery for everyone. In this graph, I'm trying to show those two trends. So we see, on the x-axis, the trend going from, open surgery all the way to, non-invasive micro-nano future type of surgeries. We see some of the intuitive, systems, the XI single port, and then the ion here on the no autonomy scale. And already in the open surgery case, when you think about, laser eye surgery, if you think about orthopedic surgery, if you think about, radiation surgery, we already have highly autonomous systems in FDA approval and in clinical use. But where really autonomy is lacking is in the soft tissue space, where things deform, change, much, much more difficult to, develop systems that are robust in doing soft tissue surgery. So big white space, and we see kind of like a major, some major jumps due to AI, and they're going to present some of our work to show you a little bit how we can achieve those jumps into that big white space that is still open. So traditionally, including our 2022 work with the STAR robot on suturing, we used a model-based approach. That means we had to, separately find a target in the tissue, track it in 3D, then model how our, tool interacts, and then send the robot to do some interactions like suturing. This is very well understood in the robotics community, quite predictable. But, really doesn't scale well. It took us, 10 years to develop, a STAR robot to get it, to, a laparoscopic animal study. And there we had maybe stitch-to-stitch success rate of about 70%. So there's clear limitations of this. So we used AI for some parts of it, the perception stack, some of the planning stack as well. But we hit really some limits with this model-based approach. In the last few years, now we are using a pure learning-based approach, learning from demonstrations, and that can scale then much better to different tasks. So one framework, and then we add more data and learn different steps just by adding more data. We started this work by really looking how to use imitation learning effectively for some of these basic surgical tasks. That is a collaboration with Stanford, Chelsea Finn. We investigated lifting tissue, needle pickup and handover, knot tying using the Da Vinci Research Kit. The only addition that we made to the robot adding is two wrist cameras that provide an additional view. On a high level, really quite simple. We watch expert surgeons perform their operation. We take in as input the surgical video and the wrist views, and then train a transformer diffusion model to learn how to act. So we, map the vision input to the action of the robot. And so what does the surgeon see? What does the surgeon do? And create this mapping with the AI transformer architecture. And with just a few hundred demonstrations, we were able to show that we can perform, tasks like knot tying quite robustly here, completely autonomous using this policy, trained with 500 demos, about 90% success rate on suture pads. So we really learned these kind of basic surgical steps. Here we pick up a needle and exchange it, to the other tool. So we are ready for suturing. And then lifting tissue is the easiest task, 100% success rate in about 200 demos. What is cool about this framework that it's quite robust to disturbances. So it's not sequentially programmed. So it really looks just at the current video input and then performs the action that it learned from the demonstration. So here we knock the suture thread out of the grasper and it repairs itself and finishes the task really nicely. But this is just suture pad, right? It's not yet clinical. So over the last year, we worked on getting this from basic tasks to phases of surgery on much more tissue-like specimens. And so we worked on the gallbladder surgery, cholecystectomy, in an ARPA-H grant, and just published this earlier this summer in Science Robotics. We are focusing on the middle phase of cholecystectomy, the clipping and cutting of the cystic duct and artery. So this is, the clipping and cutting phase that we really focused on. So we trained on ex vivo specimens, getting about 30 gallbladders, in our lab. And you can see even in healthy pigs, quite diversity on the appearance of these ducts and, artery structures. And performed repeatedly each of these sub-steps. So we divided the clipping cutting into 16 different sub-steps, trained repeatedly on each of these ex vivo samples to collect maybe about 16, 17 hours of surgical video for this phase of the surgery. We use similar approach to what Greg mentioned, the language of surgery. We analyze the history of the video and then first create a language command that tells us what phase of the surgery are we in, what step of the surgery are we in, and then also, is the procedure going well, or do we need to make some corrections? And that feeds then into a low-level language condition policy that executes the robotic action. What's nice about the language is that the surgeon can super easily intervene. So the robot tells you, I'm gonna clip the left artery, and you can say, no, go to the duct, right? So it's a really nice way of interacting. And in the training phase, we can also then update the policy so that we, really take into what are the steps that the surgeon wants to perform. And that is the final result. You can see this, clipping and cutting phase now completely autonomously. So there's no no human interaction, other than exchanging the tools for the new clip and, of course, the cutter. But all the direction is done, autonomously. You can see the pulling on the gallbladder head to create some space, and then slowly, getting into the cystic duct with placing 3 clips. Then in the with the cutter, with a scissor, cutting in between the second and third clip. Sometimes you see a small misplacement and then, repairing it and adjusting to, finish the task. Overall, we did 8 consecutive, gallbladder clipping cutting phases and didn't need any, human interaction. Here you see kind of those 8 videos, side by side that we were able to perform, autonomously. So really nice demonstration that something as complex as a, significant phase of the surgery in soft tissue context can be performed with, autonomy. So with that, I want to thank the team, at Hopkins, my lab, the great students and postdocs that worked on this, and then also really acknowledge, the funding. A lot of this work was funded by ARPA-H. And really thank you for your attention. I'm happy to answer any questions or, discuss this further in the panel. Thank you.